And our next speaker, again, we would like to call Dr. Andrei Schimdt. Dr. Andrei Schimdt is a pioneer in the endovascular treatments, as his well-known name. He's the head of interventional department of the Hospital Park of the Leipzig, Germany. Please, Dr.
Yeah, thank you very much for the introduction. And yeah, could you connect my computer? Just a second. So my talk will be about the role of stents. Just a moment. Yeah, fine, thank you. So stents, so now I have to concentrate on stents. Will it be covered, drug-eluting stent or bioabsorbable stent? What will be the future? And clearly, of course, there has to be a little bit of overlap to the talk which I gave in the morning. And I have to restrict myself to stents and not talk about drug-eluting balloons, which is not so easy for me. My disclosure slide again, and well, you have seen this. So this is what we have, what we know from stents, nitinol stents. First, second generation for SFA lesions. Also first, let's call them first generation vial bands. You see that for shorter lesions, it's acceptable. It could be better. So nothing really reaching over 80% here, primary patency after 1 year. However, if it comes for longer lesions, there's clearly quite a big gap here for good results and a lot of place for better results. Silver PTX, as I showed you already, has changed the landscape. It showed that achieving 80% patency, even more, nearly 90% after 1 year is possible in the SFA with the drug-coated stent from Cook here in this randomized trial. However, also here you can see this is rather short lesions included into this randomized trial. These lesions, of course, are not those where we have a lot of restenosis. The longer ones are the more problematic ones, but also for these we have better results now with the Silver PTX. First, however, here the 4-year results I also showed you already. The curves already reached a plateau here after 1 year, and the benefit of the Silver PTX stent remained. Also for longer lesions, not randomized, but we have this big registry, the single arm, and these were quite a lot of patients treated for long lesions with the Silver PTX. Mean 226 millimeter, patency nearly 80% is also quite good and clearly better since compared to what we had so far for the SFA. This is a long lesion and also an instant restenosis, which we have treated finally with the Silver PTX stent. You can see here that this lesion we have treated, quite narrow artery here, not really a case where we should be proud about. After ballooning, this was done in an area in a time where we didn't have drug-eluting balloons and also no Silver PTX stents. So due to the fact that balloon doesn't work here, we implanted here bare metal stents here with this result. Patient was fine, no claudication anymore. However, after 11 months, the patient came back with recurrent claudication due to this reocclusion, and we treated this here once again with balloon with a lot of dissection, no good results. So we thought, well, if we want to have a flow here, we have to implant another layer of stents. Bare metal stents, once again, double layer of bare metal stents, not something which we, as I said, should be proud of, but the result was quite good. However, it didn't really keep open for a long time. 9 months later, it was reoccluded. And we had to treat this once again, plain balloon, only device which we had available during this time, really. And the fourth reocclusion came back quite early. And this was, again, after balloon angioplasty, again with a good result. However, this didn't really last long. And we were really quite desperate what to do. And then we had the Silver PTX stent available, and actually we implanted here a third layer of stents, which we usually don't do. You can see here the results, and this is after 32 months, and it really demonstrates here that this stent works also in long lesions, also in in-stent restenosis. I find this example really quite impressive, and we have here also the 44 months ultrasound results. It's still patent here with the Silver PTX stent in. So it changed the benchmark, as I said. Now it's around 80%, which we have to achieve in the SFA, and you can see this, that we, with Silver PTX stent, we can achieve this. What about covered stents. This is the first randomized trial, the first generation, I want to say, Viabahn compared to nitinol stents. In long lesions, you can see here the patency rate of 58% with Viabahn, 53% with Viabahn is not really good and has to be better. The main reason for failures were edge restenosis. We know this. It's mainly the isolated proximal restenosis or proximal plus distal, which then leads to a sudden occlusion of the Viabahn. And this is a nice example showing this very short restenosis at the proximal end. So therefore, the technology was changed to a contoured edge here proximally, which leads maybe to a better alignment of the Viabahn into the arterial vessel. There's also heparin coatings, so two new technologies on this Viabahn. And with this, the Viper registry was done in long lesions. You can see here that now with this newer device, you can achieve better results than with the older Viabahn here in the Vibrant study. And we have now another randomized trial, the Viastar trial, with this new Viabahn compared again to bare metal stent. You can see here that with Viabahn now in longer lesions, you can achieve better results. Maybe not so much for shorter lesions, I showed this already, but for longer lesions here you can see a difference, especially because bare metal stents are very bad in long lesions. So again, this graph here, silver PTX and the Viabahn now in a similar range here, especially for long lesions, difficult to decide. We must acknowledge really that the Viastar study is the first randomized controlled trial in long SFA lesions. This is, I think, very important to have here, but I don't think it's up to date to compare a Viabahn to a bare metal stent. It should be maybe better compared to a silver PTX stent, and this we don't have so far. That clearly would be interesting to have. What we sometimes do, and it was mentioned already, to avoid edge restenosis, also not to jeopardize here maybe the origin with the Viabahn and the collateral, that we do not only implant a Viabahn, but maybe take a silver PTX stent here in the proximal part to avoid overlap of the Viabahn here, and a silver PTX stent here to avoid overlap of the Viabahn or the collaterals. And maybe also by this we can avoid this edge restenosis. So this might be a way to go in the future. A very interesting concept, but so far no data. But clearly, does it fit into a time where we think we shouldn't leave nothing behind with drug-eluting balloons? Clearly not. This is again full metal jacket and even more. There maybe bioabsorbable stents could be an option. So what do we have? We actually studied the first polylactic acid stent already quite some years ago. However, now finally published it. It's a non-randomized prospective multi-center study using this stent in 30 patients, quite short lesions. Technical success, very good. But you can see here the restenosis rate was really quite high. 68% after 1 year is not avoiding restenosis, but maybe rather inducing restenosis. So it doesn't really work very well. Why do restenosis, are they so high? Is it maybe because of an inflammatory reaction to the foreign body? We have taken some of the material out here by TurboHawk and analyzed it. It was mainly hyperplasia, sometimes maybe a little bit of inflammation, but altogether it might be a good idea to combine it with a drug, and we have initiated a trial combining this stent with a drug-coated balloon. The other way to do this is maybe to use this Esprit drug-eluting bioabsorbable stent or vascular scaffold from Abbott, which works here with everolimus. It's a balloon expandable polylactic acid stent. And you know this, it's now already investigated in a very small registry, prospective, single-arm, multi-center, evaluating the stent in short lesions. Professor Lama is the PI. You can see here the technical success was very good. Most of them were in the SFA. Lesions were quite short. And however, so far, after 6 months, the results were really quite good without any major adverse events. However, so far, we don't have any results about the patency, and we have to clearly wait for this. So to conclude, I think drug-eluting stents and new generation Viabahns seem to improve results for the SFA. Maybe especially for long lesions, they might be a good solution. Bioabsorbable, clearly so far disappointing. in combination with drug elution. Very appealing concept, but very far away until we know really. I think there are more interesting concepts, and currently, for example, we are comparing the silver PTX stent to a drug-eluting balloons and also long lesions in a multi-center trial in Europe, and we will see whether here the silver PTX stent will be ahead or maybe not. Thank you very much.
Thank you, Professor.